Induction of labour. What is induction of labour? If you are offered an induction of labour, it's important that you have enough information to help you decide if it's the right decision for you. Induction of labour is offered when it is felt that birth will benefit the health of either you, your baby, or you both, compared to waiting for a natural labour. It means that labour will be artificially started. There are many reasons why this may be offered and different ways of making this happen. Before an induction, your midwife or doctor may offer to perform a membrane sweep. This is an internal vaginal examination in which your midwife places a finger within your cervix, which is the entrance to the womb, and stretches it with a sweeping circular movement. This should stimulate the release of hormones called prostaglandins, which may encourage your labour to start. This may be uncomfortable at the time and can sometimes cause light bleeding. It is up to you if you choose to accept this. Why would I be offered induction? There are a variety of reasons why induction is offered, including prolonged pregnancy. Some risks increase as pregnancy goes past 41 weeks. The risk of stillbirth rise from 0.04% at 41 weeks to 0.35% at 42 weeks. This will be discussed with you to help you decide if induction is the right path for you or to make a plan if you feel you would like to wait longer. Waters breaking after 37 weeks. If labour doesn't start spontaneously after your waters break, the risk of you developing an infection increases. The option of immediate induction or to wait up to 24 hours for labour to happen on its own will be discussed with you. Complications occurring in pregnancy. Other reasons induction may be offered to you include diabetes in pregnancy, high blood pressure or preeclampsia, a small baby or a baby that is not growing well, and reduced movements from your baby. All pregnancies and circumstances are different, and your doctor or midwife will discuss this individually with you. Preparation. There are two main parts to the induction process. The first part focuses on the preparation and opening up of the cervix, and the second part is the breaking of the bag of water around the baby and getting your body into active labour. An induction is artificially stimulating your body to labour, sometimes when it is not ready. Therefore, you can expect this to take time. Your cervix needs to respond to the process, and we do not know how long it will take. It could be anything from 1 to 4 days. You may wish to discuss if the option of going home during the first part of the induction is appropriate for you. If you are going to stay in hospital for the whole of your induction, you may want to think of things to take which will help you pass the time. Most units will allow your partner to stay with you, so they may need to pack some items for themselves like food, some toiletries, and a change of clothes. Methods of induction. There are different methods that can be used to induce labour. You can discuss the options offered locally with your midwife. On arrival, the midwife will examine your tummy and confirm your baby's position. Your baby's heartbeat will be monitored for a short time to ensure your baby is well. This will be done using a CTG machine, which will also monitor if you are having any contractions. The midwife will offer other routine tests like checking your blood pressure, pulse, temperature, and urine. You will then be offered a vaginal examination to assess the cervix to help you make a plan about which method of induction may work better for you. You may hear your midwife or doctor refer to a Bishop's score as part of this assessment. A lower score will mean your cervix has not made many of the early changes in preparation for labour, whereas a higher score means some of these initial changes have begun. Your options will be discussed with you, so you understand the plan and what that means for the next few hours until another review. Prostaglandin gel or tablets. If your cervix is in the very early stages of changes, prostaglandin gel or tablets will be considered. The gel or tablet is inserted into the vagina near your cervix to be absorbed. The midwife will want to monitor your baby and contractions for a short time after giving you the medication. You will then be encouraged to walk around when monitoring is finished. A reassessment will be 6 to 8 hours after the first dose was given to you, unless there is a reason to do so before. Occasionally with this method, contractions come on too frequently. If this occurs, you may be offered another medication to bring the contractions back to a manageable level. Another option is prostaglandin pessary. This will be offered when your cervix is in the early stages of change. The pessary is inserted into the vagina near your cervix and slowly releases the hormone to be absorbed over 24 hours. It has a string like a tampon, so can be removed early if contractions become too regular. The midwife will want to monitor your baby and contractions for a short time after giving you the medication. You will then be encouraged to walk about when monitoring is finished. You will be offered an assessment in 24 hours unless there is a reason to do so before. If this method is used as an outpatient form of induction, the midwife will discuss with you all of the situations where you should either call or come back to be seen. Mechanical methods. Mechanical methods include using a small balloon or rods that are inserted into the cervix and work by stretching the cervix by gradually swelling up over 12 to 24 hours. These methods require a speculum internal examination, similar to a smear test, to be able to insert the small balloon or rods into the cervix. These may be more suitable if you have had a caesarean birth before, as it is less likely to cause strain on your previous caesarean scar. This may also be used in an outpatient setting. Next steps. Once your cervix is open enough, you can move to the labour ward, where breaking your waters is the next step of the process. From this point of the induction process, you will require a dedicated midwife to provide one-to-one care. Sometimes there may be delays in transfer to the labour ward until a midwife is available to provide this care. Sometimes breaking your waters is enough to bring on contractions to establish your labour. If this doesn't occur, a drip containing a synthetic hormone called syntocinon is used to get your contractions started. This is a synthetic hormone which is similar to the one naturally produced in the body. The drip is gradually increased until you have 3 to 4 contractions every 10 minutes. It can take some time to get to this point, and the drip may make labour more painful than natural labour. Your midwife will talk to you about your pain management options available to you. During the second part of the induction process, continuous monitoring of your baby's heartbeat using a CTG machine is required to ensure that your baby is coping with the labour. This may restrict your ability to be mobile. There is a risk of bringing on too many contractions, which is called hyperstimulation, and this may cause distress to both mum and baby. There is some evidence to suggest that induced labours may slightly increase the risk of needing assistance at birth with forceps or Avon-2s. Unsuccessful inductions. Sometimes induction is unsuccessful. If this happens, your medical team will discuss a plan with you. This might include a rest period, further attempts to induce labour, or a caesarean birth. This will be a conversation personalised to your circumstances that takes into account how you and the baby are and your preferences. Induction of labour may not be a path you expected, and you will need time to process the information and choices. You can decide to proceed with, delay, decline, or stop an induction, and your decisions will be respected and supported. To find out more, visit sneewellbeing.org.uk/maternity.